end of the presentation, Molly will answer those questions as best as she can. So don't hesitate. Keep your mic on mute if you can. And here we go. Thanks, Molly.
Well, thank you, Sharon. That was a very nice introduction. I appreciate that. And I don't know if you guys can see the questions coming. If there's anything you want to stop for, just please interrupt me. I don't mind at all. The biggest thing I will say is that I really, when I was training for pediatrics, I did not receive any special training at all in Down syndrome. And once just the regular training that we all get. And once I got to Franklin, very early in my career here, Tiffany Wensler, who I don't know if you guys have met her or not, she became one of my her daughter Etta became one of my patients, and we just kind of hit it off. And shortly thereafter, she and a group of very impressive people wanted to start a GiGi's Playhouse here and asked me to join, and I was very honored to be part of that group. It was a fun process. I think it's a great organization with a great facility, great volunteers, and I'm glad you guys are all on here listening today. Please, though, any questions, let me know. I'm kind of going to talk a little bit about just the first few years and things that may be the same as typically developing children and things that may be different with individuals with Down syndrome. So if I can make this work, I'm going to share my screen. Okay. All right. Let me just, can you guys see all this or just you can just see the presentation?
Yeah, correct. We just see the presentation.
Okay, perfect. Okay. All right. So in individuals with Down syndrome, some of the critical developmental skills that we look for in children occur at different rates. That doesn't mean you're not going to get there. It just means the time frame that you look for is a little bit different. And therefore, when you look at websites that may have expected ages for things to happen, may not be what you're looking for. And I think that can sometimes be difficult, but as long as you remember there are charts and things out there that can help you decide too, and your pediatrician is always a great source for that. So one of the things here that I kind of broke down is the big areas of development in the first few years that we're looking for: motor skills, language skills, and kind of the interactive social skills and self-help, feeding yourself, those types of things. And if you look, one of the things I think most parents look forward to is that first smile. When you smile at your baby and your baby smiles back at you. And you can see that one, in individuals with Down syndrome, I have it listed, but usually happens between 1 and 5 months. And in individuals without Down syndrome or developmental delays, it usually is between 1 and 3 months. So it's very early in development. And that's one of the first things that I think people ask about and look for, like, when is my baby going to smile? And it's going to happen usually in those first 6 months. That is something that's pretty critical that we look for, because it actually tells us a couple of things. It talks about vision. Can they see what your face is doing? It helps us know about hearing. Can their baby hear when you're smiling, when you're talking to them? So as well as I can copy those facial motions that you're doing. Some of the others, you can see there is a variability there of huge ranges for a lot of these, right? So something may happen at 9 months in one child and it may not happen until 2 in another child, but that can all be within that normal range of development. The one I really want to focus on a little bit on that social self-help is the potty training, because I know that can be a huge frustration. So especially as you're heading into school years, and know that it is coming, and just because a child isn't completely potty trained by the time they start kindergarten, that doesn't mean it's never going to happen. Okay, so usually that is by about 6 to 7 years in individuals with Down syndrome. The other thing I will say too, especially on the dressing self, is that you always want to be sure you're giving your child the opportunity to learn. Sometimes it's really easy to do things for them all the time, but that's not always the best thing for them. So, it may be that at first it's just putting one leg in a pants, and then you're putting the other one in and pulling them up. And then maybe you put both legs on and they pull them up, and eventually it gets to where they can pull both pants up. But it takes time, and sometimes, again, it's just reminding yourself, hey, I wonder if Aiden can do this yet. Let me give that a try, right? On language, and we'll talk about language a little bit more later, but communication is a part of language, as is articulation, and those are very different things. And so just because a child isn't saying a word doesn't mean they're not able to communicate. That's where things like sign language comes in, and picking up visual cues and behavioral cues as to how they're communicating with you. And I think at GiGi's, some of the sign language classes can be hugely beneficial when those are offered. But that can be a way to bridge that gap. If the words aren't coming, the articulation isn't coming, you can still have conversations and communication with your child, even though they're not saying words. And then on the motor skills, there's lots of therapies that'll happen in the first few years, lots of intensive physical therapies, lots of exercises, lots of practicing. I spelled rolling over wrong, sorry about that. But you can see that there are, again, very wide variations in when things are going to happen. And just because a child isn't walking at 18 months, you should not be discouraged by that at all. At all. That is something that will come, and it just takes a little bit longer. Individuals with Down syndrome have very low tone, and because of that low tone, everything they do takes a lot more effort and a lot more strength, and they can become fatigued easier.
Dr.
And so,
Hood, could I ask you a quick question? Could you explain a little bit more about what low tone is? Is that something that's, is that neurological? Is it like muscle strength? What is that exactly?
Right, so it's kind of a combination of both. But in general, the neurologic system and attachment to the muscles, as you try to flex a muscle, you may feel a certain tightness or a certain strength to that. Children with low tone are unable to create that force, and they also can have looser hyperflexibility and looser joints associated with that as well. So you may hear of children just with low tone is described as floppy muscles or floppy tone, where they just can't hold that up. That is something that can be worked on and improved, but children, or for whatever reason, who have low tone, that low tone is usually always going to be lower than a typically developing person. But you can improve strength and coordination regardless of that. Is that okay?
That's great, thank you.
Sure. So I remember there was early in GiGi's Playhouse, we had someone come and talk to us, Derek Young, who I don't know if any of you all know. And one of the things, he's a leader, she talks about a lot about leadership, but he also has a child with Down syndrome. And he was talking about, if you went to school all day and had to sit or at work all day, and everything you did was harder and took more effort to do, you would be exhausted when you would come home. And that's true with young children, not just in school. So a therapy session of 30 minutes may not seem like a lot, but that can exhaust or wear out a child too. So a 2 or 3-year-old who goes to a therapy session, and then maybe their behavior is not quite where you think it would have been on a different day, it might just be that they're tired and need some rest. So anyway, so the goal of this slide really to let you know there's a huge variation, and there is a understanding that you are going to get there, even though it takes a while. One of the things that really helps with that, and I think probably if most of you are probably already involved in Tennessee Early Intervention Services, or if you're at a surrounding state, one of the, every state has this, they're called a little something different in each state, but Tennessee Early Intervention Services, or TEIS. And I think there's a couple of really important things to be sure you're aware of with this. It is a state program. The TEIS is offered for children aged birth to 3 years old. At 3 years old, all of these services transition to your school district. And so it may help with that transition to services. Anyone can refer. It does not have to be a doctor referral. A family member, friend, teacher, anybody can make a referral to TEIS. And there's a very long list of diagnoses, including Down syndrome, that automatically qualify for services. And the earlier, the better. You know, you can get referred as soon as you get home from the hospital and get those services started. Early intervention for language skills, for physical therapy, for physical skills, gross motor skills, for feeding skills, the first 3 to 5 years are really critical, and that's why this early intervention program exists, so we can get kids the most help they need in those first years. They can achieve the goals that you want. The biggest thing I think too to remember is a lot of insurance companies don't cover everything for therapy that you might like to do. This is offered at no cost to the families. So if you qualify for services, they set up a plan for you, and there's no cost to you. They do charge your insurance. They get funds from the state level, from the federal level, as well as from Medicaid services. So hopefully everybody is involved in that already. The thing I think that a lot of people get bogged down by in the first probably a year to 18 months is doctor's appointments. We know, everybody knows they're not fun. In a child with Down syndrome, you probably have double the appointments in that first few months because of the specialists that you're seeing. Most individuals with Down syndrome will be seeing, you know, an ENT, an ophthalmologist, perhaps a cardiologist, a GI doctor, maybe an endocrinologist, as well as your primary care provider. And I just want to say, I know I'm a primary care provider. I think it's important to have someone who can kind of coordinate all of that care and be sure that every screening is getting done that needs to be done. I think you need to have one person who's kind of following along with the growth, because, you know, the ophthalmologist isn't gonna, the eye doctor is not going to check your weight when you go see them. And also someone who's monitoring that development pretty well. There is also, you know, the standard every child checkup routine from birth till age 3 is listed there. So you're seen pretty regularly. The other important thing there are the vaccinations. You know, there's a very standardized recommendation from the American Academy of Pediatrics for vaccination, and those are really important to stay up to date on. There are a few other things that some children with Down syndrome may qualify for, especially in the first year. Something called Codiagnosis. If you have a heart condition with Down syndrome and in daycare or other high-risk illnesses, you can sometimes have to get something called a Codiagnosis shot, which is for RSV bronchiolitis. But
Aiden was a candidate for that. Aiden got his Codiagnosis shots. They were so much fun.
So much fun every month for like 5 to 6 months.
Yep, but it was a big deal to get those Codiagnosis shots. I will remember, because it really did have to be a candidate. At the time, he was in respiratory distress as a newborn, and then to add on to that, he had a heart defect. So those Codiagnosis shots they come with some kind of, it does, just because you have Down syndrome does not automatically qualify you for those Codiagnosis shots.
Right. It is a very strict criteria, because while it's not a vaccine, as everybody's heard a lot about vaccines versus monoclonal antibodies lately in relationship to COVID, this is actually an antibody treatment. And so it only lasts for a month. So you have to get it every month from October, usually through March or April, depending on where you live. And it used to cost several $1,000s per shot, which is why there's very strict criteria as to who qualifies for that and who can get that. It is less expensive now, but I think it's now like $2,000 per shot. So it's cheaper, but it's not cheap. So there's a very long list of qualifications for that. But that's something that if you have questions about, just ask your doctor. There's a very detailed list on that. One of the things that's kind of, I won't say controversial, but has changed some in the last 5 years, and that is the Down syndrome growth chart. So the old Down syndrome growth charts were created many years ago, I should say. And things have changed a lot, right? Like nutrition's changed a lot, treatment's changed a lot, therapy's changed a lot. And therefore the expectation for children with Down syndrome has changed a lot. And so the CDC, back in 2015, did a new growth chart for Down syndrome and looked at a new group of kids with Down syndrome and tried to see if we could adjust that a little bit. And what they did find was adult growths were higher, so taller, and growth in the first year nutritionally was much better. And so those growth charts were revised. So it's just one of those, it's a small detail, but it can make a big difference when you're looking at those growth charts. And you can always plot a child with Down syndrome on the old ones, but just understanding that those slight variations. Those are something you can print out yourself from the CDC website. If you just go to cdc.gov Down syndrome growth charts, you can print those out and track your own child's growth if you would like to. So you don't have to rely on the one from, that the doctor shows you at the office. So you can print those out and track them yourself. There's one for kids under age, it kind of goes up to 36 months, and there's one for children age 2 to 20. Body mass index is not different for typically developing children or children with Down syndrome. So body mass index, where the weight and the height together, is the weight and the height together. And that's something that can be plotted on any growth chart. One of the really important things I think it's nice for families to have is this next thing I've referenced here, the healthcare information for families of children with Down syndrome. And you can get it from the healthychildren.org website. That is the American Academy of Pediatrics website. This is a list of everything that should be checked in the first month, in the first year, between ages 1 and 5, in the school age, and then in the teenage years, because the recommendations for screenings for kids with Down syndrome are different than for kids without Down syndrome. So some of those are, every child in the United States gets checked for hearing at birth. It's usually birth, then maybe at 1 to 2 years, at 3 years, 4 years, and then at school usually after that. However, kids with Down syndrome are much higher risk of hearing loss for both structural reasons as well as congenital hearing losses. So that is checked pretty regularly, and most children will need to be referred to an ENT for evaluation by age 1 year. Now, there are other children who, from the time they come in with Down, like the first visit, I can see all the way to their eardrums, and that's not the norm, but it does happen. And in those children, sometimes because they have a more normal anatomy, they may not have to go as frequently, but that is one thing that's checked more frequently. Vision problems are not uncommon either in individuals with Down syndrome, and those can happen at any time. So at birth, vision, and we check for certain things in the eye, but then it's usually by a year, and then every year you're seeing ophthalmology at least once a year. The biggest things that you're looking for there, the eyes may seem crossed or one may wander, or there can be eye movement changes where it looks like the eyes are shaking. Either of those can be a big concern. So even if you see an ophthalmologist and everything's great at 12 months, if at 18 months things are crossing or wandering, and then you just call them up and say, let's go do that again, and they get you in again. Low thyroid levels are very common in individuals with Down syndrome. The most common, well, I would say almost everybody by adulthood will be screened really regularly, and it's really more than half of the individuals with Down syndrome end up on thyroid medication. So, we usually check that in the first year. We check that every year after that as well. And that thyroid can be asymptomatic, so you may not know that that's going on. So just because we're like, oh, they're not tired, they're not having constipation, they don't have dry skin, they're growing okay, you may not see those signs. So it's something that even if you don't see the signs of that, you want to get that checked every year. Same with anemia or low iron levels, very common. And it's just something when you're doing that yearly blood work, you do that as well.
I just want to jump in here real quick, and I just want to remind all the families here, if you're feeling a little like, oh God, there's so many things to check, I want to remind you that there's a very easy peasy checklist at the healthychildren.org website. All you have to search for, you can even search in Google, AAP Down syndrome checklist, and it comes up for you. It's very simple of all the things that you need to check. It's very reader friendly, and it's good to have just on hand at your child's well check visit, just so that you remember the things that the AAP suggests that you check.
Right.
So don't feel too overwhelmed, because this information is all laid out for you, really easy to find.
Yes, and I would actually recommend you take that in with you to your doctor's appointment. I have one of those in each patient's chart so that I can look at it to see where that needs to go, because, you know, pediatricians are usually, the things that we check on everybody, we know off the back of our hands. If you're only seeing, you know, 5 children with Down syndrome, you want to be sure and double check that you're seeing on those. And I will guarantee you, nobody will be offended if you bring those in. We will be appreciative if you bring those in with you, okay? And that's why I put that on that first slide. That checklist is there for a reason. The key to remember is that you may, if you have a child who does not have Down syndrome and one who does, their checkups may look very different. And that's what I think is important to remember, so that you don't have, you know, it's not the, well, we didn't check that on my first son, but now I'm checking it on my second son, that type of thing. The one thing I would say you always want to bring up, constipation. I mean, not that you want to bring it up in casual conversation, but it is something that is very, very common in individuals with Down syndrome. And don't blow over it just like, oh, it's just constipation. That is something that you always want to bring up and discuss with your doctor as well. There are some tricks that can help you and make life easier, but there are also some things we might screen for, like thyroid, like celiac disease, that may be beneficial, and maybe it'll be life-changing with some very minor changes. The other thing I will say that I think people don't think about, because you don't always see it, is sleep apnea. Not in the early ages, not in like up to about age 2, but starting around age 2, 3, 4, sleep problems can start to happen, and those are not something you necessarily can diagnose like you could for an adult for sleep apnea problems. So if I have sleep apnea, I might snore like crazy, fall asleep easily just sitting down, be really fatigued through the day. But children with Down syndrome, you may not see any of those signs. And so it's important to remember, oh yeah, nobody likes doing a sleep study, but it's important to have those done periodically. And then
also, as a parent, just recommend, because Aiden has not gotten his sleep study yet, and I'm literally dreading it every day.
Yeah. Yes.
It probably the younger-ish, you want to try and tackle that, because sleep study, man, they're going to have some probes on their head. They're going to have, it's just not going to be a fun night. And so probably I'm more, yes, but it's recommended before 4, but I'm kind of wishing I did it like a year ago. So just as a little disclaimer, go ahead and get that done when you have time.
Yeah. Yes, age 4 is not the easiest age to do things in general. So sometimes you may want to have that done a little bit earlier. And it's especially important if, we want kids, if they were to need surgery for something, if an ENT is going to put tubes in their ears and do something under anesthesia, and they need something done for their sleep, it sure would be great if all that can be done at once, right? So limiting the procedures as best we can. Sometimes that's not possible, but if they're getting ready to have tubes put in and they're 3 years old, and you're like, hey, maybe we should get that sleep study first just to see if we need to do both at the same time. And again, dental visits in children also not super fun sometimes, but important to do. And I would also say, don't worry about teeth that don't come in until later. They're common. Children with Down syndrome can have missing teeth, but it's nothing to be too concerned about. And the tooth eruption patterns can be different in individuals with Down syndrome, as well as delayed a little bit. So if your child doesn't have any teeth at a year, don't worry, they're coming. That's the other thing to remember.
Be thankful. That's all I have to say. Be thankful.
That's right. So about all that, we'll come back to those questions on those. But I just want to say one quick comment about respiratory virus season. It is cold and flu season. We are rapidly approaching that. And this year is a little different with COVID. It's here. Hopefully it'll go away by spring, summer with everybody getting vaccines, but it is not going away this winter. And so doing everything you can to stay safe with that. Kids who are old enough can wear masks. Nobody under age 2 should wear a mask, but over age 2. Hand washing, staying away from crowds, all of those things. But I would also say that kids in general do very, very, very well with COVID. Even children who have some medical issues have done really well with COVID. So while you should be concerned about it, you shouldn't panic or isolate more than everybody else should because of that. Say it that way. Flu, however, is a little bit of a different story. You know, flu is a much more dissimilar illness to COVID in that it causes respiratory issues, but it is actually a much more harmful illness to young children, especially those under age 2. So, you know, the number of hospitalizations for COVID has been very low, but in a typical flu year for the last 10 years, anywhere from 5,000 to 30,000 children are admitted to the hospital with flu. That's just under age 5 every year for things like pneumonia, dehydration, encephalitis, brain inflammation. So all of those things can occur, and the biggest way to protect yourself for that, other than hand washing, you know, good hygiene, is to get a flu vaccine. And the first year you do get a flu vaccine, you have, if you're under age 9, you have to have 2 separated by a month. Just a reminder for that. And also, all the other good, fun wintertime viruses are out there: bronchiolitis, the RSV we talked about a little bit, strep throat, colds, all of those things. So don't just because somebody has a fever, don't assume it's COVID. Right now, I think we all are kind of in that one frame mindset, but there's all the other stuff is still out there too. So be sure you go get checked out if you need to. All right. I don't know if that's all. If y'all have any questions, that's all I kind of have. I appreciate your time, but if there's any questions, I'm happy to answer.
Thank you so much, Dr. Hood. You're awesome. I have a question for you. Nobody asked this. I'm asking this. I'm going to take this time as my personal Q&A session. So if nobody asks questions, then it will be okay. We do have a question, but I'll ask this one first. What if your child who is 3 or over 2 will not wear their mask? You know, are there things we could do to help them, or is that something that we should be really worried about, or what do you think?
Yeah, so I would say there's a couple of things you can try. One is make it a game, make it fun, practice wearing around the house. When you're not in crowds or not in a distracting type environment, that can help. And this is, by the way, this is true for all kids, not just individuals with Down syndrome. But you practice wearing them. Practice, make it a game, give rewards. I'm all about bribery when it comes to things like that. Maybe not always candy. Think of stickers and stamps as well. But that type of thing can be great. The other thing is, be sure, you know, as we all have found, there are some masks that are way more comfortable to wear than others.
Yeah.
You know, so finding ones that are softer on the inside instead of the throwaway disposable surgical mask. I got to tell you, I wear one all day. They're not super comfortable. They're kind of itchy. They've got little things that poke on them. So children may be more bothered by that than sometimes the adults.
Definitely. And with the flatter nose bridge too, you know, it's almost, that makes it tougher for they kind of slide down all the time. I've wondered though if the flatter nose bridge almost makes it a little bit easier so that things aren't coming in as much, but that's just my my thoughts at night. So I'm not sure.
Well, and I will say the other element that comes in, as someone who wears glasses, and a lot of children with Down syndrome wear glasses, that adds a whole nother level of complexity to it, right? So the fogging of the glasses is no joke. And so trying to figure out a way that you can keep that from happening. But I tell people, you know, kids, you think, how are they going to keep glasses on? And they keep glasses on. So they can do the mask too, usually.
Mm-hmm. All right, we do have a couple questions for you. Our first one is about infantile spasms.
Yes.
Do you have any thoughts about Down syndrome and infantile spasms? And specifically, this person is asking about what about infantile spasms and being treated with prednisone, and if that makes them more susceptible to illness.
Okay, so infantile spasms are more common in Down syndrome, but they are still pretty rare. So that would be the first thing that I will talk about. And if you don't know what infantile spasms are, it is basically a type of seizure that you see in infants, and it's pretty characteristic when you see it. You can Google pictures of it and see it online. But in general, the treatments do help, and while chronic high-dose steroids do increase your risk of some infections, it is not. It's more harmful not to take the steroid, if that makes sense. Okay, so there are certain things you have to be cautious of with when you're on high-dose steroids, and that's live virus vaccines like chickenpox and measles, mumps, and rubella. There are, depending on how much you're taking and how recently you've taken it, there are some restrictions related to that.
And I also would just like to add from just from a parent perspective, I've been in a group with lots of parents across the country with kids with Down syndrome around the same age. And so if you have any concerns about your child perhaps kind of like zoning out or kind of looking up and not really being able to make eye contact for a few seconds, just keep that in the back of your mind, not to freak anybody out, but it does happen. And so just to be kind of aware, even better, go to an infantile spasms webpage. I don't know which one it was, but there are videos out there too that might kind of help you get an idea of that. Just to put it out there, it does happen with kids with Down syndrome.
Yes,
so
it does. But it's a very classic. If you watch the video, which I'm sure you did, Sharon. Like you see, it's a clench and a cry, and you see the pattern.
Yep. All right, another question is, we have a comment that says, yes, Basking glasses are a struggle for us. So that is a struggle for everyone. Yeah. Is there a limit for how many times a child should go under anesthesia, or are there any risks with anesthesia and Down syndrome specifically?
Yes, there are risks, but are not related necessarily to anesthesia. So I will mention that in a second. As far as the anesthesia, we always try to limit the number. Like if they can combine a surgery, they're going to do that, especially at a children's hospital. Just to kind of, because every time anybody has anesthesia, there's always a little bit of risk. The risk with Down syndrome comes into play with neck instability. There used to be a recommendation for all children with Down syndrome to get an x-ray of their neck beginning around age 3. That recommendation no longer exists unless there are what we refer to as neurologic signs associated with that. By the way, all those neurologic signs are listed on that health supervision list. So I won't go through all of those, but it can be weakness, it can be numbness, it can be head tilt to one side. But the concern is there can be a laxity or a looseness where the head and the neck attach to one another. And as you can imagine, that sounds scary, right? Yes.
Yeah.
Yes. And so the biggest risk comes in with anesthesia, with head positioning of the neck, depending on what surgery is being done. Okay. And so sometimes a surgeon may need to get an x-ray of the neck before a procedure, but in general, what has happened with pediatric surgery, especially ENT surgeries, where that positioning is oftentimes significant, they all use universal precautions for that instability. So they assume everyone has it, as opposed to assuming no one has it and only you have it if you have an X-ray.
Okay.
So there is that risk. And so if someone brings that up or says, hey, you need to get an X-ray before you have surgery, that's what they're talking about more than neck than anything else. But
that's really
there
good
are
to
still
know.
some programs like Special Olympics, I think on their form still wants an X-ray. I think some of the horseback riding programs still want it, but in general, that's universal standard recommendation is no longer there.
Okay.
Yeah.
Great. That's news to me. I'm glad I'm here. I'm learning new things. We have 2 more questions so far.
Okay.
Should we be using Tylenol on our children with Down syndrome? Is that
Tylenol? Oh, go ahead. Is that the end of the question?
That is the end of the question. I think probably is Tylenol a negative thing for kids with Down syndrome? Is I think perhaps where that's going.
Yeah. So Cheryl will probably tell you I don't recommend a lot of medicine in general, but I will say that if a child needs fever reduction, if they have pain, I think that it is perfectly fine to give Tylenol. I would not give Tylenol kind of just in case they have a fever after their vaccines. Oh, did I change? Okay. I saw that my computer screen just changed. So I didn't know what's going on.
It would be helpful for us to see you a little bigger than the screen. But keep
okay, gotcha. Okay. So I think Tylenol is perfectly fine. There are a few, Tylenol is easy to dose. It tastes good. There's one concentration of it now, which makes things a lot easier. Ibuprofen should never be given to anyone under 6 months of age. And if there are any kidney issues whatsoever, you really want to talk to your doctor before you get approval for giving that. So just to make sure.
Is that
the ibuprofen
at 6 months? You mean
anybody, any age? So if you have kidney issues, the non-steroidal anti-inflammatory, so ibuprofen, Aleve, those types of things, you want to be sure it's okay for you to take those because there's different levels of kidney issues, and just want to be sure it's okay. Ibuprofen, the kidneys of kids under 6 months of age are not fully aren't kind of functioning quite at the level of an adult yet. That's why we also don't give babies water. And so you don't want to cause any damage or inappropriate clearance of the ibuprofen, so you never want to give that under 6 months. That's true of everybody.
Okay. Our next question is, how common is it for children to also be diagnosed with ASD, autism spectrum disorder? My 3-year-old loves spinning in circles. Is there a specific reason he does things like that?
So autism and Down syndrome is not uncommon co-diagnosis. You know, and even if you're looking at just general population, that number is about 1 in 80 to 1 in 90. And when you think about that, that's true also for Down syndrome, right? So you've got to watch for that. And when you already have speech that may be delayed in general, it's a little bit harder to diagnose sometimes, those co-diagnoses, and it can sometimes take a little longer. You will see kids spin all the time. Kids will do it for fun. If that's the only kind of sign of autism, that self-stimulatory behavior of spinning, I don't think that's a concern. If you have a long list of things that perhaps are occurring, that would be more of a concern. And that's true with any child as well.
Okay. I used to be being a special education teacher in the past. I think, you know, some of the things that we would look for are, as the psychologist would know, would be things like, is the child avoiding eye contact, or it seems painful to make eye contact? That would be one of those things to look for. Yes, the stimming could be a thing. I'll let you know. Aiden loves to stim with certain things, but I really don't think he has autism.
Right.
He loves to wave socks around. I don't know what it is, man. He just loves those socks. And so and he loves spinning in circles too, and that's not to negate the things that you're seeing. You know, if you do have concerns and you're worried about things, definitely bring it up to your doctor. but just know that there's usually multiple things that need to occur for an autism diagnosis to be given. Okay, sorry, does that sound right? Okay.
Yes.
I'm sure you would correct me if you thought that
Yes.
that I was off the mark there. And if you have any more questions, folks, please put them in the chat box. Otherwise, this is going to be our last question for the evening. Another question on infantile spasms. How long after they start taking prednisone should you see them start to return to normal? That is smiling, laughing, etc.
So that's a really tough question to answer. Every child is very different with that, and kind of their response to therapy. So, you should have a follow-up appointment rather quickly with your neurologist after starting that, after you start medication, and then that should be, they may look for subtle changes first before you see the more dramatic changes later on. Yeah. But it can be extremely variable.
Oh, and we have another question come in. Why is it that leads schools, I'm sorry. Is there a way to, I'm sorry, oh, another question came in, so that's why I'm confused. Okay, why is it that Down syndrome behavior leads to schools to recommend ABA classrooms? So when children with Down syndrome exhibit problem behavior, why do schools recommend children to be more secluded into more behavior specific classrooms that are getting more behavior intensive intervention? I think is what this person might be asking. Is there a way to avoid this or to teach the schools about the behavior? Yes. Okay. So I think that might be more of an educational question in general, kind of like a school system kind of issue. So let me just think about your question. Why is it that Down syndrome behavior leads to schools to recommend? So ABA is applied behavior analysis, and that's specifically a kind of intervention to help kiddos learn a multitude of things, but one of those things can be more behavior programming. And that is a strategy, or it's almost like a curriculum in a way that people who are professionally trained to do can teach these things. And if you and your school are not agreeing or seeing eye to eye about those things, then I would definitely suggest that you immediately call a meeting with the school so that you can sit down and have those discussions, because the way that you may be feeling about that behavior should definitely be brought to the table, if that makes sense. So I hope I'm addressing your question, Paulina. But I think that's more of in the educational realm, which, by the way, you're more than welcome to hit me up, because now I'm a parent IEP advocate. So send a message my way. But I think we'll leave it there. Does that sound good? Okay. That is all our questions for this evening. Hey, we did it. Oh, one more.
Okay.
When treating a cold and flu, what is the difference between albuterol and an inhaled steroid?
Oh, that's a great question. That is a great question. Okay, so in children who have wheezing or bronchospasm or asthma, as you get older, who've gotten that diagnosis, the airways get narrowed and become more sensitive to things. And so the albuterol works instantly. Okay, so the albuterol is something you take, it relaxes the muscles around those small airways, they open up and decrease, hopefully, the wheezing. So it is a treatment for acute, like episodes of wheezing that are happening right then. Okay. Inhaled steroids, things like Pulmicort, Flovent, Q-Bar, those are some of the brand names that you may have heard of. Those are what we refer to as preventive medications. So you take those every single day, even when you're not sick, in order to decrease the inflammation in the lungs so that the wheezing doesn't happen when the triggers occur. So the goal is, if you just have wheezing every now and then, your doctor may just give you an inhaler. You use it once or twice, of the albuterol, I should say, once or twice a month, or just a couple of days when you have a cold. You don't use it for 6 months. There's other kids who wheeze all the time or have frequent episodes of colds associated with wheezing. Those children may need to be on an inhaled steroid so that those don't happen as frequently. So the inhaled steroids are there to prevent the inflammation and the wheezing from actually occurring.
It's good information for us too. We do struggle. We just so you know, you're not the only one who has a kiddo who struggles with those things.
Yeah, and I will say sometimes we'll do shorter term courses of the inhaled steroid, but in general that is the difference there. And that's a great question. I will tell you the difference in those two medications. I think we as a medical community don't do a great job of telling people sometimes, because there's a lot of confusion between those two and in what episodes that you're using them. There is something that's called an asthma action plan, which is a written out plan that if you are on a daily inhaled steroid or controller medications, your doctor should have and be able to write out and give to you. And it kind of tells you, this is what you should do every day. This is what you should do if there's a cough, a cold, or a wheeze. And this is, it's like a green, yellow, red kind of plan. And so in the red zone, this is what you should do. Call us immediately. Those types of things. But it really breaks it down. But it's called an asthma action plan, and every pediatrician or family medicine doctor should have access to those.
Awesome. That's great to know. As you as parents head into not meetings, but appointments with your pediatricians, know that you are your child's best advocate, and that you know your child better than anyone. And so if you have questions and concerns, and it is very important that you ask your doctor specifically about how to explain things, ask them more information, because a great doctor will not hesitate to explain those things to you and to help you feel in charge of your child's health. But on that note, I think that's it. Did you have something else?
Well, I was going to say on that note too, oftentimes we tell you a whole bunch of things that are kind of commonplace to us because we say them all day long, all the time. But you might walk out the door and be like, wait, what was I supposed to do with that nasal steroid or the nasal spray, or which nasal spray? And if you feel that way, just ask us to write it down. We all just write it down for you. Just, write it down so it's easy to do. We'll do that frequently for people, just because when we're talking about eczema care or skin care, or, we're talking about different creams and different do this and that. And sometimes you get home and it's kind of like, wait, I don't remember what, and I do that too when I go to the doctor. You're like, which one was I dose in the morning? So I think it's one of those things, just ask them to write it down if there's a long list of things you're talking about.
I love that. That's a great tip, because you do that for us every time. And Aiden is very energetic and all over the place. And I'm like, just trying to wrangle him. I'm like, just write it down. I'm not really sure. So great tip. All right. We got a lot of thank yous. Awesome. Great presentation. Thank you so much for this meeting. Very helpful for a new parent.
Oh, thanks.
And so we're so glad that you were here. Thank you for volunteering your time to be with us.
My pleasure, and I apologize for the technical issues, but I think it worked out okay.
It did. we figured it out, and maybe like go see your husband and be like, the webcam didn't work. What's going on?
Fix this. That's right. That's right. All right. Well, thank you guys for allowing me to join in. I appreciate it.
We really appreciate
Have a good night.
you. Thank you so much. And for everyone out there, we will post this video on our YouTube page. So if you want to go back and revisit something, or if you'd like to share with a family member, we will have that posted probably by tomorrow afternoon. And if you have any questions or want anything else answered, just email me and I can pass along the information to Sharon or Dr. Hood. And thank you, Molly. This was so awesome and very, very helpful.
One more thing I just thought of, guys. Make sure, if you want to get links to all the YouTube videos, if you want to find out about future sessions, go ahead and join the Extra Connection Facebook page. That's where we're trying to keep all this information together. And you can look forward to our next presentation, which we will drop tomorrow, so you can be excited for that. So just go ahead and join that group if you want all the up-to-date information. We'll post resources and all that kind of stuff. All right, that's my last one.
Bye-bye.
Bye. Thank you.
Have a good night.